It's time for another Morning Point Foundation Caregiver Cafe, part of the work of the Morning Point Foundation, providing nursing scholarships and caregiver support programs across the Southeast. Thank you, donors, for supporting our 4 annual Seniors Got Talent shows and our 2 annual golf events. And now, bi-monthly virtual caregiver cafes featuring senior living experts. This episode features Dr. David Hutchings, a PhD in geriatric neuropathology and a dementia specialist in Spring Hill, Tennessee. Dr. Hutchings works with the Alzheimer's Association on the state and national levels for clinical education. He serves as a faculty member at John Patrick University in the Department of Dementia Alzheimer's Medical Program and co-chairs the university's Cognitive and Memory Disorders Clinic. He is founder of Dementia and Alzheimer's Care, LLC, a private practice firm focused on the evaluation, treatment, and clinical education of all forms of dementia. Please welcome Dr. David Hutchings to the Morning Point Foundation Caregiver Cafe.
Thank you so much, and good evening. First, I want to say thank everybody else for jumping on. We've had a tremendous amount of folks RSVP to this lecture, so we're very excited tonight. I do want to extend out a thank you to Morning Point for all the work that they have done on this, putting this together. As you heard in the intro, my name is Dr. Hutchings. I am a neuropathologist, and I specialize only in Alzheimer's and dementia. I have recently, in the past year, merged my practice with Blue Sky House Calls, who service about 2,000 patients across 7 different counties in Middle Tennessee. So I work primarily with Blue Sky at this point. For today, you're gonna notice I'm a very laid back kind of speaker. We're gonna have plenty of time towards the end for Q&A, so I want to make sure I get to a lot of questions. So we're gonna have time for that. But what I want to do is I want to kind of set the stage here. I always ask myself, I was like, why do we not ask the same questions in the world of dementia that we do for cancer, for example? If somebody came to me and said that you, Dr. Hutchings, you have cancer, my first question would be, what type of cancer do I have? Next question would be, what stage is it? And then lastly, how are we going to treat it? And by the time we get done with this presentation tonight, these questions are things that you should be asking yourself as caregivers, as patients, and even as practitioners. So let's jump in and get started. I'm going to go ahead and share my screen real quick. Give me 1 second. Okay. All right, let's jump in and get started. So what we're going to cover tonight, a little bit on prevalence and statistics. I do want to differentiate the difference between dementia and normal aging process. And then we're going to talk about some common forms of dementia and different types of dementia. And this is really critical because we treat different forms of dementia differently. And so we're going to go into that in great detail. One of the big pieces too is we're going to talk about dementia staging and how we assess it and exactly what stage means what. And then we're also going to talk about, with the time that we have left, is talk about some symptomology, addressing some behaviors, depression, anxiety, and also sundowning. So if we look at the prevalence of dementia, the question I get often is, why do we see so many patients now being diagnosed? So I'm going to answer this kind of out of 2 sides of my mouth, if you will. People are not necessarily living longer. They're living longer with chronic diseases. So we have what they say in the research as the silver tsunami. We have the roughly 7,918 people every day turning 65. Mathematically, that's around 330 people per hour. So we have that silver tsunami. We also have what we call a gray tsunami. We have a diagnosis of Alzheimer's every 65 seconds. And by mid-century, which we're coming close to that, we're going to see a diagnosis of the Alzheimer's every 33 seconds. And this is only one form of dementia across 85 different types. When we do look at in terms of the impact that we see in our assisted living facilities, which myself and Blue Sky service a lot of the assisted living facilities, we see about 68% of those patients have some form of dementia in an assisted living facility. And of that 68%, about 34% of them have significant behavioral symptoms, whether it's anxiety or depression or whatever it may be. And of that 68%, we have about 27% of those patients are going to be more in the moderate to severe in terms of the severity. So as we go through this evening and talk about different types, the different stages, and how do we treat, I want to introduce you to a lady named Grace Kirkland. Grace Kirkland really helped curve my career. I was able to meet her family at a very young age. At 66, she was starting to have some memory issues. She was really cooking. She really loved to sew. Very involved in her church. And when, later on, within a few years, she started having significant memory issues. As we start to talk about different types, I want to introduce you, and we'll show basically 3 clips of Grace as we go through this presentation. So this is the first clip of the 3 clips I want to show you in this evening's presentation.
And tomorrow's Sunday, isn't it?
Is tomorrow Sunday?
Tomorrow's Sunday. What do you do on Sundays?
We go to church and sing a song, sing. So,
What songs do you sing in church?
Jesus loves me, this I know, for the Bible tells me so.
What about, do you sing glory, glory?
Glory to hallelujah. Glory, glory, hallelujah. Glory, glory, hallelujah. He's coming again to take me to heaven.
That was a nice end. You put a different end on it than I know.
Little R-I-D-D-L-E, R-I-D-D-L-E.
You got that one real fast.
Well, I work these old puzzles so much, and I know, and S-Q-U-A-R-D-A-N-C-E.
Guess you found it already.
I can see these in my sleep almost.
So if I look at Grace there, I actually had a patient of mine one time, and I can sit here tonight and give you all these different textbook definitions of what dementia is. But this patient looked at me one time and she said, "Dr. Hutchings, I don't feel like myself." And I thought to myself, that is by far the greatest definition of dementia that I've ever heard, because it doesn't only impact memory. We see behavioral changes, we see personality changes, we see the loss of problem solving. So it's not just memory. And I used the analogy of cancer a moment ago, okay? And so I want you to kind of think about that again. And if we had cancer as an umbrella, we have many different types of cancer that fall underneath that umbrella. And one of the common questions I get is, what's the difference in Alzheimer's and dementia? Well, think about dementia as that umbrella. And underneath it, we have Alzheimer's, and we have many different forms that we're actually going to talk about tonight with that. Dementia and Alzheimer's is not a part of the normal aging process. Believe it or not, we don't have memory loss as we get older. Our brain is like a computer. It shrinks as we get older, and then we start to have some slowness in processing, but we don't actually have memory impairments. But some of the things that are not associated with normal aging are frequent memory lapses. I know this bullet point is towards the end here, but I see this a lot: difficulty handling money or paranoia with money, difficulty finding words, repeating conversations. These things are not a part of the normal aging process. And in just a few minutes, I'm going to talk about prevention as well as with Alzheimer's, because I do get a lot of questions when it pertains to that as well. So before we diagnose somebody with dementia, we want to make sure this is not a progressive neurological illness. And many people don't know, but the word dementia actually is an acronym. We can have, so for the D, I see many patients with depression that may mimic an Alzheimer's. They could be a drug interaction. We can have some thyroid issues and endocrine problems. It could be more metabolic or epileptic. It could be nutritional issues. There could be some trauma or toxicity. There could be blood flow issues or more structural issues. But if we look at all these different types of dementia, again, 85 different conditions that can cause some form of cognitive impairment or dementia, what do they all have in common? They all have in common what we call the 5 A's. So yes, we have memory loss, we have amnesia or short-term memory loss. Some dementias don't have that right away, but they are going to at some point. And then we have the loss of language. And when we approach Grace in the second video, you're going to see the loss of language. And if you remember in the first video, you might be surprised if you think about when you watch that, Number one, we ask ourselves, what can a patient still do? And she actually never spoke a word at all in that first video. She sang everything. She sang to communicate. So we do have a loss of language, and the loss of the ability to actually produce speech like I'm doing now, or the loss of understanding speech is what you're doing now. Next, they have what they call apraxia. This is basically the loss of motor movements. This impacts our ability to walk, our ability to talk, our ability to eat. And if you're a caregiver or just on this lecture this evening, just to learn more, if you want to know what it feels like to have apraxia, try to write the word association, or maybe even your name. Now, I'm right-handed, but I would want you to do that with your non-dominant hand. And that's what it would feel like to have apraxia. We also have what we call agnosia. And I know all of you, or many of you on the conference tonight, have experienced maybe a loved one who does not recognize your face or doesn't recognize maybe their home anymore. And that is agnosia. It's a loss of the ability to recognize a face or a place. And we're going to talk about when that happens, at what exact stage here in just a little bit. And of course, we do have attention and concentration deficits. So let's jump into the more common type of progressive neurological dementias that we see. Alzheimer's. We don't have near enough time tonight, but there are multiple different types of Alzheimer's. We have vascular dementia. We have Lewy body dementia, which is kind of near and dear to my heart because my father-in-law has Lewy body. So I'll talk a little bit about that as well. And then we have Parkinsonian dementias, and then we have a rarer form of a group of dementias that are called frontal temporal lobe dementias. So I want to kind of break this down a little bit for us. As we jump into Alzheimer's, what happens in Alzheimer's is that there is a gene that mutates. And it basically, that gene's responsibility is to remove the fats and lipids inside the brain. When it mutates, we get an abundance or more of a collection of those fats and lipids that create the plaques. We've heard about that. And then we have what we call the tangles. And if you can think about a railroad track, on a railroad track, you have two parallel bars and you have perpendicular bars. Well, if those perpendicular bars are removed, what's going to happen to the railroad track? It's going to shift, and then we're going to tangle. And so it's a mutation of these genes that create those plaques and tangles. Now, there are a lot of myths out there on Alzheimer's, that memory loss is a part of normal aging. We've already talked about that. It is not a part of normal aging. People do not just get older and get Alzheimer's. That Alzheimer's disease is not fatal. It is, but we're going to talk more about tonight and things that we know we can't cure it, but we can treat the symptoms. And I want to talk a lot about that here as we move through the presentation. Only older people get dementia. That's actually false. I have many patients in their 40s or in their 50s or even younger. And then there are no treatments to stop progression. And so that is actually true, but there's a lot of wonderful research going on that we're working with the Alzheimer's Association on to stop. Because I'll be very honest with you, I hope one day I get a call that I'm out of a job. And I'll know at that point that we've reached a cure for the disease. I published an article a couple years ago on how to prevent dementia. I wanted to include this slide tonight because this is something I get a lot of questions on. Now, I talked about that gene a moment ago of Alzheimer's. Now, if you have let's say your mom had Alzheimer's, but your dad did not, you have a 3 times chance higher of acquiring the disease. If both parents have Alzheimer's, you now have 2 copies, and that gives you a 12% chance higher of acquiring Alzheimer's. But if we look at a certain population, for example, the Nigerian population, they have the highest prevalence of the Alzheimer's gene and some of the lowest prevalence of Alzheimer's. So if we look at how we can prevent, we need at least 6 to 7 hours of deep sleep per night. We need more of a Mediterranean type diet. We need to make sure we're not eating big meals before we go to bed, because again, whatever you digest, the brain has to digest all those fats and lipids too. We always talk about physical exercise. We talk about that all the time, but the brain is the only organ aware of its own existence. Think about that for a second. The only organ aware of its own existence. And it can sometimes be somewhat lazy. So we have to cognitively stimulate our brains. And that can be done through learning a language or learning a musical instrument or whatever it may be. but also it can be done through social, being social. It helps stimulate the brain. Depression and making sure we're not smoking, maintaining a healthy weight, and then certainly alcohol consumption. So if you want more information on the article I published, I'll give you some contact info at the end of the lecture, and I can get you all that article. The second most common form of dementia, and I actually saw a patient with this today, called vascular dementia. And my father-in-law actually, or my stepfather rather, actually has vascular dementia. And this is caused by either one major stroke or lots of small strokes with an extensive cardiovascular history. These patients, like the patient I saw today, literally looked like he had Parkinson's. But I realized when you start dissecting and looking at the imaging that this is not Parkinson's, this is actually a vascular dementia. I refer to this one as like the Tennessee highway. It's a very up and down, up and down. There are some days these patients can be extremely lucid, and other days they can't. So think about it as kind of a stairwell. They'll plateau for a little while, do well, and then they'll have a quick drop. And what we see in the brain is we basically could see here, we have kind of a lot of spaces in between and a lot of black spaces. And that's just the shrinking. But we see all these little white specks. And this is the vascular component that causes patients to have a vascular dementia. They will have insomnia. They'll have hallucinations. They'll have gait abnormalities. They have personality changes. So it's much, much different than what we would see for an Alzheimer's patient. Next, if we look into the different types of Parkinsonian dementia, I remember when I was in residency, I had a neurologist tell me that Lewy body dementia is just a textbook term. But ever since Robin Williams passed away and he had Lewy body, now that brought an incredible light onto this condition. These patients are quite different. They have extreme insomnia, and then they have extreme hallucinations, very vivid hallucinations. But the difference between these two dementias are quite significant. So basically, if we have these odd hallucinations, extreme insomnia, very up and down type memory, some patients can be able to recognize you perfectly and then tell you what year it is, but then within a few moments, they'll become disoriented again. So here's how we want to kind of break this down. If you have those cognitive, or a patient has those cognitive deficits first, and then they develop Parkinsonian symptoms, like Parkinson's symptoms, that is a Lewy body. If it is reversed and a patient has Parkinson's first and then develops dementia, that's where we end up having a Parkinson's with dementia. And the hard part here is because it impacts their sleep. And just as I mentioned on prevention, you have to have sleep for memory. So we have to be able to control the sleep as well as the hallucinations. Now, here's the thing, is if I treat a Lewy body patient, or if I treat a Parkinson's with dementia patient the same way I treat an Alzheimer's patient, I can actually accelerate that dementia and make it worse. So this goes back to my point, everybody, is we have to identify the type of dementia, or we are going to be lost when it comes to the actual treatment of the condition itself. Now, some of you on tonight may have experience with your loved ones, maybe a frontal temporal lobe dementia. And this term, basically, it is what it sounds like. It is a shrinking of the frontal portions of the brain, and then the left and or right temporal areas of the brain. They are fairly rare. They tend to be more genetic, where Alzheimer's disease tends not to be as a genetic condition. This statistic isn't on here, but I would say that for 1,000 Alzheimer's patients you'll see one frontal temporal lobe dementia. It is quite a bit faster in terms of how it progresses. And there's more types than just three, but for tonight I wanted to highlight three. There's a behavioral variance. And I have a patient right now that literally has lost his social filter. He'll say things socially inappropriate. They'll say things sexually inappropriate. He'll get aggressive. He's lost that social filter, and he's beginning to lose his ability to speak. And then we have primary progressive aphasia. And this is where, if you can think about, you have two filing cabinets in your brain. One controls your ability to, the one that I'm using now, I'm opening that filing cabinet and I'm putting words that I know into a sentence to convey a message. Next, we have what you're doing, which I hope you're listening. You're going to understand what I'm speaking to you. So imagine going to Mexico and you don't speak Spanish. That's what it would feel like to have this dementia. You lose the ability to speak and understand speech. And then we have a semantic temporal variant. And that is also a loss of language. But for example, if I had a patient with this and I showed them a picture of a Christmas tree, and then I show them a picture of a palm tree and say, which one would we see on the beach? They wouldn't be able to tell us the difference. So if we see this in imaging on a postmortem examination, you can see the deterioration, those gaps right there in the frontal portions of the brain. So it impacts our, our empathy, our social filter, our language, those types of areas. And they do tend to onset much earlier, typically in the mid 50s to early 60s. So changing gears now, if we look at cognition, I'm going to define cognition as everything that you are. It is your beliefs, it is your family, it's your experience, it's everything. So it's not just short-term memory, long-term memory, things like that. It's everything that you are. Remember, the brain controls everything in your body. And so dementia doesn't only impact our ability for memory, but it also impacts our physical ability as well. So when I'm assessing a patient, I am assessing multiple different types of areas of cognition to determine where their impairments are. But again, going back to Grace's video, what are the patient's strengths? What can they still do? And then early on in conditions, we'll see patients have inability to pay bills, sequence things, forgetting recipes. These are more high level type cognitive abilities. And we start to see some of those having impairments first. I do house calls. Okay. So I still see patients in their homes. And these are some of the things that I'm looking for when I'm also assessing a patient. So we talked about our filing cabinets, and that's, again, your ability to express yourself and then understand speech. I want to be very clear that if a patient is unable to speak, it does not mean they can't understand what you're saying. Again, those filing cabinets are housed in two completely different areas of the brain. So I want to show us the second clip of Grace now. This is just a few years later from the first clip. And I want you to think about the language pieces and see the changes that Grace has gone through in the next just few years from the last clip.
Oh, tells me so.
Good. Okay, very good. Some lunch. That's it.
It's been 10 years since Grace was diagnosed as having Alzheimer's disease. I have retired and stay home caregiving for Grace full time.
No, just wait a minute. Just a second there. Just a second. No, just a minute.
Over the years, Grace's condition has deteriorated. Her memory loss is so extreme that she can no longer take care of herself.
She normally can eat reasonably well once I get her started.
Now, if we look at that clip, not only, and I wish I could ask you all these questions and get input, but what I see is that, number one, she didn't speak at all, but she was still able to do some things. She was able to feed herself, which is tremendously huge. That reduces our risk for pneumonia dramatically. But also she didn't speak at all during that. So she has that filing cabinet of being able to express herself has been deteriorated, but she's still understanding speech. And the last thing I see in her is that I definitely see that we are having a weight loss. I can see that with her. And so that's something that I'll be looking at too as we talk about dementia staging. Before we get into dementia staging, let's talk about some of the medications. Now, I know a lot of you are very probably familiar with Aricept, Exelon, those types of things. As we talk about dementia staging, I want to kind of bring this up, is that these medications work wonderful when we're in the early stages. So just like cancer, when we stage a patient, it's on a 0 to 4 scale. Well, in dementia, it's on a 0 to 7, 0 being normal, 7 being profound. So if I have a patient in that mid 4.5 to 5 range, these medications are not going to be doing anything. They're not helping anymore. So my goal then is I'm going to control the symptoms, the depression, the anxiety, the sleep issues, the sundowning, these things that we know we can treat. So if I have a patient that's very early on, I might use these medicines. If not, I'm going to be using medicines that I know I know works to control the symptoms. We don't always want to throw a pill at stuff. We want to make sure that we're treating what is impacting the patient the most. So that kind of brings me into some symptom management here. This is a short slide, but I can tell you right now that if I had dementia, I would not want to feel anxious. I would want to make sure I'm sleeping. I wouldn't want to feel depressed. And these are things that we can treat. As we talk about sundowning here in a few minutes, it's something that we can treat. It's actually a treatable condition. We look at medications like Seroquel as a very safe medication in the world of dementia to help do several things. It helps us address anxiety. It helps us with sleep. It helps us with sundowning and behaviors. I had a patient today that is very aggressive during whenever we try to change or do any kind of bathing or dressing. So we scheduled these medications an hour before those events happen. And so we didn't make any, amazing changes. We just scheduled those medications in such a way that they're getting those medicines, they're starting to kick in when the patient is going to be bathing or having these other types of care needs that they have where they're not going to feel so anxious. Trazodone, it tends to be one of the safest medications for sleep. And then, of course, we have to treat the SSRIs for antidepressants. And if you get one thing out of my talk tonight, think about this, is that nearly every one of these patients are going to have anxiety or depression. And we have to treat three things. We have to treat the dementia, we have to treat the anxiety and the depression as two different conditions. So we have to treat many different things. But also, I want to know who that patient was before they came to me. If they had, I want to know what they did for a living. I want to know what their interests were. And I want to know, did they have anxiety? Did they have depression? Because these things are going to get worse when the disease begins to onset. I will voice this from a mountaintop. I am not a fan of benzodiazepines. That's like Xanax. These medications are not good for dementia patients, and they actually have the opposite effect. If some of you take a Xanax, it may calm you down. In some of our patients, it may hype them up. So we have to be very careful in terms of the medications that we use. And again, be careful on the medications we use on the type of dementia that we're dealing with. Now, we talked about cancer at the beginning. So now we have a type of dementia that has been identified. Now we want to look at what stage it is. So when we look at staging, there are different tools out there. And some of these tools have been around since Adam and Eve ate the apple, okay? I mean, the mini mental status exam has been around for a long time. And we get a score on this test, and that's all we get. So let's say we have the highest score you have is a 30, and then you get a 15. When I talk to the families about that doesn't mean anything. So the question is, what is impacted at that 15 out of 30, and what's coming next? And this gives our caregivers and our clinicians and our practitioners within the facilities to know what is coming next. So if we break down that test, and this is great research. So this, if you look at this, remember 30 is normal. If we have a 25 to 30, we're going to have trouble keeping appointments, preparing meals. We could have mobility issues, medication management. So we can start to see now we have a score and we can see what's happening. But what happens next if they drop below 20? Then they're going to have their overall safety in the home is compromised. Their bathing and dressing, communication, these types of things. And then we get below a 15 is when we have more eating issues. And that's kind of what we're seeing out of Grace right now. We can have more behaviors, loss of appetite. So if I'm running tests on somebody and know that we're a 23, these are the things I'm focused on next because I know this is what is coming next in the disease process. And what kind of help or calmness does that give a caregiver to know what is coming next and how to prepare for that? Now, I imagine all of you that have probably gone through cognitive testing, or you've seen your loved ones gone through cognitive testing, you have done the clock drawing test. Again, I'm kind of laid back. I'm going to tell you right now, I don't care if a patient can draw a clock, but what I'm looking at when they do the clock drawing test, there are the numbers bunched over onto one side. If the numbers are bunched over on the one side, that gives me two things I'm concerned about. Number one, they're driving. And number two, they're a risk for falls. Because visually spatial we now have deficits in our visual spatial. So if I'm driving, a car stops in front of me, I know exactly how to apply my brake because visually and spatially, I know how far that is away. Or even walking, going downstairs. Well, if we see these numbers bunched over on this one side, we know that number one, driving is a huge risk, and this patient now is at a risk for falls. So now let's go into staging. So remember I said earlier, 0 is normal and 7 is profound. When we're looking at staging, I'm looking at the ability for a person's concentration. I'm looking at their recent memory, their past memory, their orientation, and their ADLs. And once I test all these areas, I can then look over to the actual stage and get a stage for the family. Now, and then when I reassess every 6 months, let's just say if a patient is at a 4.2, I'm going to come back 6 months later and see, has that 4.2 changed? Now, we don't actually have dementia until we get to stage 4.0. We have mild cognitive impairment from stage 3.0 to 3.9. And in that MCI state, I'm going through that dementia acronym. I'm looking at the thyroid. I'm looking at, is there depression? Is it a medication issues? I am doing the best I can to check everything off this list before I say this is vascular dementia or this is Lewy body or Alzheimer's. Things change when we get to stage 5. This is where we're going to need some type of 24-hour care assistance. So if I staged a lady this morning, she was a 4.2. And I know within the next 8 to 9 months, she's probably going to be at that stage 5. So I'm working with the family to say, okay, I know we want to keep her at home as long as possible, but this is what she's going to need within this number of months. Or do we need memory care or whatever it may be? So it really helps us kind of plan ahead. When we get into the 6 range, this is where I'm really focusing on their ability to swallow. Can they maintain their weight? Can they feed themselves? Because I don't want to put the chance of this patient developing a pneumonia. So it really, in kind of a summary, we have a stage. We have something, we know exactly where this patient is, but it helps me predict what's coming next. And at that point now, myself, the clinical staff within the facilities, you, the caregiver, you are now ahead of the disease process because you're not having to rush to make decisions. You know exactly what's coming next in the disease process. So the dementia staging is when I do a neurocognitive assessment, that is one of the things that I'm doing. I'm getting a dementia stage and a diagnosis. So now I've answered 2 of the biggest questions that we started in this lecture. What type of dementia do I have? And what stage is that? Next, I also look at caregiver and their caregiver burden. I can tell you right now that the emergency rates right now are skyrocketing for those that are caring for patients with the dementia. We're even seeing in some research is that the patient is actually outliving the caregiver. And if you're on tonight and you're caring for somebody with dementia, you know that this is the toughest journey that you will ever endure. And it does take an impact on your health as well. So I'm not only assessing the patient, I'm also looking at the caregiver as well. I have a lady that a patient of mine has been extremely anxious, and his wife would call me multiple times, and I could see it in her eyes. She was wore out. And so I knew we were at stage 4.8. And I said, we got to do something in terms of your health, but also get this patient in a safer environment because stage 5, they need that 24-hour care. So once we have the neurocognitive assessment, we have all these tools, we have the stage, and we have the diagnosis, we can start to care plan. And when we look at care planning, I want to keep a patient at home as long as possible. I really do. Whether or not that's at their home, whether or not that is in independent living, my overall goal is to keep quality of life up as long as possible. And if any of you see me as your doctor later on, if you're currently seeing me, one of the things I ask my patients that are early on the condition is, what do you want? What are things that make you happy? Because yes, we can get the stage, we can get the diagnosis, we can get the medication set, and all that is fine. But I want to know what the patient wants and what the family wants, and that plays a major helps drive the care that I'm trying to provide. When we get into stage 4, that's where assisted living is really a good environment. As long as the patient's not an elopement risk, that stage 4.0 to 4.9 is definitely very appropriate for a patient in assisted living. But when we get to that stage 5, that's where we really need more of the 24-hour care. I hope this doesn't frustrate anybody on this conference, but I like to be very straightforward. I don't like to send my patients to nursing homes. And if that frustrates anybody, I'm sorry, but I want to keep the patient in their home, whether that home is the assisted living, whether it's at their home, or whether it's memory care, that is still their home. And I want to make sure that we kind of divert that skilled nursing stay. So if I'm looking at the staging process and I know that we're at a 6.2, I can then start to talk to the family and then the staff at maybe it's Morning Point, and say, we're going to start to think about hospice now. And hospice doesn't mean that a patient has a certain life, a certain time within 6 months to live. I've had patients on hospice for a year or two, but it gives us an extra level of care. And so I'm anticipating, and that way we can have these talks and these meetings with the families in case conferences and say, this is the next decision that we have to make. We're a stage 6.2. We're going to have to start thinking about hospice as we move along. So we are ahead of the disease the entire time. As I mentioned, we would talk about sundowning. Now, I will tell you right now, this percentage that says 66% of patients experience sundowning, I don't buy that percentage. I put that on there because that's what the research says, but in the clinical world, and I'm in the trenches every day, it's a much higher percentage of that. But basically what's happening is that we have behavioral symptoms that occur around the same time, that it happens about the same time every single evening. It could happen at 1 o'clock, it could happen at 3 o'clock, it could happen at 6 o'clock. But once we have the patients on the right medications, we can then say, okay, we're going to give these medications before that patient experiences the sundowning. The medications begin to take effect, and then you'll see that patient calm down during that sundowning period. And then also we do see a tremendous amount of melatonin decrease in Alzheimer's patients and across other form of dementias for that matter. So this is why we start to see that we do need more maybe sleep aids to help these patients sleep, because the melatonin is diminished because of the disease itself. They may have environmental fatigue. They may be being overstimulated during the day. And of course, again, it could just be a medication piece. So it's almost like a puzzle. You want to go in and figure out what type of dementia am I dealing with here? What medications are best? What is this patient? Who were they before? We're going to treat the anxiety. We're going to treat the depression. And of course, we don't want our loved ones anxious and showing behaviors and aggression because of sundowning, because it is incredibly easily treated. So if you're caring for someone right now in your home and they're sundowning, please understand that can actually be treated. And there are medications that we use to really adjust that, adjust the right dosages for that patient, but also to address the sundowning. So I'm going to show the last clip of Grace here, and then I'm going to open it up to, I'm going to do some finishing comments, and then I would definitely want to open it up to some questions as well. So this is the last clip of Grace, just about 3 years later from the previous clip that you just saw.
Step down. Step down. Step down. That's a girl. That's the idea. Okay. Now this is a real big step. This is a real big step. We're gonna have to jump this one. Come on. Come on. Come on. Come on. Here we go. That's a girl. That's a stuff. That's a girl. Okay. Here we go. All right. There we go. There we go. No, wait a minute. Just a minute. Now, you gotta, let's try this again. Come on up forward here. Come on forward. That's a girl. Push her. That's just up. There we go. There we go, Gracie. Now push your bottom over. That's just out. Okay. You're gonna be okay. You're gonna be all right. You're gonna be okay. Yeah. Yeah. Isn't this a pretty day? Isn't this a pretty day, Gracie? That's a girl. That's a girl. You're gonna fuss like that all day long, are you? Huh? You're gonna fuss like that. No, don't do that. That's a girl. That's a girl. Did you join the ride? Huh? That's a girl. There we go. Okay, now chew and swallow. Gotta chew and swallow. Come on, chew. See, this is how pretty you were there. You still look pretty. You're still pretty to me. Yeah. I can't think of one thing, one specific thing, which is the most difficult to deal with. Of course, I think, I guess I can answer that, and that is the loss of a companion. I guess the point here is that I'm married, but I'm not married. I'm married, but I'm not, I don't have the companionship of the woman that I've lived with for these 40 years. And I guess if there's one thing that I think about as being the critical and greatest loss, it's just that. Grace, this is a picture of us when we were first married. Is this a pretty picture? There you are sitting in the chair, and there's me with my arm around you. Isn't that a pretty picture? See, you're my bride here. Well, my memory of Grace, of course, is as of the vivacious, outgoing, loving, considerate, all-fulfilling wife that she was in the most of the days of our marriage. We had a great time together. She was a great helpmate, and I just simply have to remember those days and try to put the days after her diagnosis into the shadow as best I can. Little ones to him belong. They are weak, but he is strong. Yes, Jesus loves me. Yes, Jesus loves me. Yes, Jesus loves me. God.
So in conclusion, I'm going to come off here so you can see my face again. You can tell I'm passionate. I am passionate about this diagnosis. I'm passionate about these patients. I've devoted my entire career to helping these individuals. I believe we can make a difference. I believe we have to ask different questions. We need to know what type of dementia that we're dealing with. It guides our treatment. We need to know what stage it is. We need to have the neurocognitive testing so we know exactly where we are in the disease process. And then we need to know how to treat it and what medications work for what patient. If you have seen one dementia patient, you've only seen one. They're so incredibly different. This is a disease that, again, I hope one day I'm out of a job. I really do. But until that point, I'm going to continue to work every single day with these patients. They don't have a voice of themselves. And I know that we can make a difference. And at the end of the day, we can not only make a difference for that patient and what they're going through, because I can't imagine not being able to know what's not coming next and what that anxiety would feel like. I want to be able to make these patients comfortable, and I want to be able to treat them to the highest possible ability that I have. And then I also want to be able to, I always feel like I have two patients. I have the patient and the caregiver, and I want to be able to help those caregivers through that journey. I have a couple of patients that literally spend every single day with their wives, every single day, meal after meal after meal. And that type of compassion is just contagious. I think that type of compassion should be the same, not only from the caregivers, but also from the medical staff and professionals that are treating them. So again, ask questions, be an advocate, identify what type of dementia we're dealing with, what stage is it, and how do we treat it? Those are the questions that we should be asking. So I wanted to make sure that I stopped in enough time that we can have Q&A. I know that we have quite a few people on, so I'm going to shoot over to the chat box here and be able to answer some questions. We have a lot of time here to have questions brought in. So if you want to start shooting questions in here, you can certainly do that. Let me just go over here where I can see the chat box here. Okay. All right. Question came in. Do you offer telehealth visits? I'm in Mississippi. Well, first of all, Lisa, I am from Mississippi. I went to Ole Miss, so hotty toddy. Yes, I do telehealth as well. And we are able to do a lot of the, at least the dementia staging. And of course, depending on the severity of the patient, we can certainly do some of the cognitive testing as well. And then if they are out of state, I'd be working with their primary care doctor or their specialist, to make sure that we have the patient on the right medication. So great question, Lisa, for sure. I hope that everyone who is traveling this road to dementia caregiver gets a chance to see this presentation. It's a must see. Thank you very much for saying that. And just let the questions keep rolling in. Another question here says, approximately what is the time frame between stages? That is, okay, who asked that question? That was Emily. Emily, that is a fantastic question because it does depend on the type of dementia. An Alzheimer's patient, I would say on average, every patient is a little different, but on average, you'll see about 12 to 16 to 18 months per stage. So if they're at a 4.6 to a 5.6, kind of in that time frame. If it's a vascular dementia, we may be at a 4.6 and drop to a 5.6 literally within a few days. So every one of them does progress a little differently. And that's very helpful for us to know what type of dementia because of the progression that it will move. And of course, frontal temporal lobe dementias, they do progress a little faster. So, we're able to kind of track that as well. Let's see here. Is there average time of the progression? So I think I answered that one from B. How can we get the PCP to get in touch with you? Do you have a number? Yes. So to get in touch with me, and if you want an assessment, I would urge you to call the Blue Sky House Call office. I'm going to put that number in the chat box, but I'll also verbalize it as well. It is 615-340-6840. So I'll say that again so you can have that contact information. 615-340-6840. And also you can contact your local Morning Point as well. Okay, I have another question here. I'm trying to get them all. Do you make copies of your presentation to be available? Morning Point did let me know prior to this lecture that this is going to be uploaded onto their website, the recording. So you'll be able to go back and kind of watch if you missed the first part of the presentation. Absolutely. Let's see here. Okay, have you seen patients with, from Corona? Okay, so a great question here from Kelly regarding COVID. I've done multiple lectures on COVID and the impacts of COVID that it's had on our dementia patients. And if you heard me mention earlier, isolation, socialization is key for cognitive stimulation. And not only do we battle COVID fog, and we have to get through that, but the isolation itself has shown a dramatic impact on our patients with dementia. So you know what? I was at one facility And we would get the patients out, and I actually sat down on the piano and played hymns, and they absolutely loved it. So this isolation is really tough on our patients here. Great presentation. Thank you. I'm gonna see here. Great presentation. Would there be any reason to be on Seroquel 50 milligram and Trazodone 50 milligrams, or are both doing the same thing? Good question by Jim. They're not doing the same thing. Seroquel is going to be helping with anxiety. It does help with sleep. It can help with hallucinations, but it doesn't do as good a job. So we're treating the anxiety through the Seroquel, but we're also, because of the insomnia, we got to have sleep for memory. If your loved ones are having impact on sleep, their memory is going to be further impacted. So those medications are doing two different things there. From Miss Sue Jeffries, hey Sue, thank you for doing the seminars. Can you talk more about a Mediterranean diet and how does alcohol affect memory? Great question. So as far as a Mediterranean diet goes, I'll say that I always don't practice what I preach. I like my steak, but more fish, more grains, rice, these types of things are very good for brain health. As far as alcohol use, in the Mediterranean diet, it does talk about a glass of red wine per day, not a box, not a bunch. A glass is very good for your brain health. But too much alcohol can onset an alcohol-related dementia that is actually called Wernicke's-Korsakoff syndrome. And it impacts the vitamin B1 or the thiamine levels in the brain, and that produces significant cognitive impairments. Let's see here. I'm trying to get, okay. My husband, this comes from Emily here. My husband has mild cognitive impairment. So that means that he is in stage 3.0 to 3.9, and his grandfather and grandfather had dementia. So is it very likely he'll develop the condition? So Emily, what I would do is I would make sure that I would check thyroid first, especially vitamin B12, to make sure there's no deficiencies there and we don't have a hypothyroidism, because those are things that control memory too. So even that we're in an MCI state, I would want to see a panel of labs, and then further I want to see an MRI to see if there's any atrophy or shrinking in certain areas of the brain. Great question. Okay. From Jennifer, my mom is currently at Pointe. She has a diagnosis of Alzheimer's disease, had a PET scan at 64 years old. Does Pointe or Blue Sky conduct regular cognitive assessments? Yes. So Jennifer, that would be me, that I would perform those assessments. Typically, I see my patients on the initial neurocognitive assessment for the diagnosis and stage and to set the medications. And then I see them every 6 months, but many of my patients I do see on a monthly basis as well. I don't want you to go see a doctor and then you go see them and you're in there for 15 minutes and that's all you get. Working with Blue Sky, what I do is I spend at least an hour with each one of my patients to make sure I'm getting everything correct for that patient. So it's not a 15-minute visit, it's at least an hour for me to do my assessment and get them set on the right medications. Let's see here. Let me scan down here, make sure I'm trying to get to this. Where is your clinic? So I actually go to the patient. I go to Pointe. I go to 70 different facilities around the Middle Tennessee area where Blue Sky House calls, but I also do home visits. I started my practice out of my church and I started seeing patients in their home. And I like doing that because I get to see the home environment. So I'm a little old school doctor that way, but I like to see patients also in their home as well. Another question from Jim here. Jim says, was it better to have an MRI instead of a CT? Mom recently was diagnosed by her PCP through a CT without contrast. A CT is okay, but I'd rather have an MRI without contrast. It gives me more detail in terms of certain areas of the brain that I can look at. I can work off a CT, but I would much rather have an MRI. Next question is, are you accepting new patients? Yes, we are accepting new patients. So again, if you want to get in touch with Blue Sky House Call, the number is 615-340-6840. So I'll be more than happy to help with that. Will patients that have injuries or falls that result in memory decline regain that loss as it heals. They can, yes, they can. But I want to try to stop the fall from happening. I mean, patients with dementia are going to fall at some point, but as long as they've not had a head injury during that fall, then yes, they're going to bounce back. But I'll say this, if a patient has a fractured hip and then they have to go through surgery, the anesthesia, excuse me, the anesthesia alone can cause a patient to have a decline. So we have to be careful there. So I hope I answered that question okay for you. Let's see here. I need to find a doctor in the Chattanooga area. Do you have an assessment from a mom and what specifically to look for? Yeah. So number one, if you're in the Chattanooga area, making sure that you see your primary care doctor. Number one, get the MRI. And if you want to contact me after that, I'll be more than happy to consult with you over the phone for next steps for your mom. Here comes another one here. How about here in Shelby County? So we could do telehealth for sure for Shelby County, and I'll be more than happy to help with that as well. Next one here said, my mother moved into assisted living in the fall. She is a stage 5, so she's already been staged. That's good. She does sleep a lot after breakfast, after lunch. Her doctor took her off the Seroquel and the Trazodone 2 weeks ago, and we'll see her in 2 weeks for a follow-up. Is sleeping during the day normal? So this is another great question. I'm going to tell you right now, if I try to sleep in Saturday morning, I'm going to wake up the exact same time I do every single day during the week. It's a sleep-wake cycle. That is also disrupted when we see patients coming into that mid-stage 5 range. So my answer to that would be, I don't care if they're not sleeping all the way through the night, but I want 6 to 7 hours of sleep in a 24-hour period, if that makes sense. If they're sleeping too much, we might need to look at the medications. They may be over-medicated and they're sleeping too much. So we're going to try to maintain the sleep-wake cycle as much as possible, but as long as you're getting enough sleep in that 24-hour period. Very, very good question there. I'm a caregiver for a 94-year-old mother, 24 hours. Her problem is more with aging. She has symptoms of dementia. I told her, I was told she has sundowning. It is very stressful. This session has been helpful. Listen, Sandra, thank you for your feedback on the lecture itself. But sundowning is very treatable, okay? It's just a matter of the right medication regimen at the right times. And it's almost like, think about it like this. If you have pain, and the moment you have pain, you take your pain medication, you're behind it. So we have to make those medications before they sundown. And that way it's gonna make it much less stressful for Sandra with that. And Sandra, I know exactly what you're going through. I know how tough that is. Next question says, my husband does not remember the question for, remember the answer for the question he has asked a minute ago, short-term memory loss. Yeah, so actually that would be what we call immediate memory. So short-term memory goes up to about 20 minutes, okay? So immediate memory loss, that is certainly a concern. So I would suggest that he be tested and identify, is this truly progressive dementia? If I was to say this, you're probably going to think I'm crazy, but most dementias are actually treatable and reversible. The progressive ones I talked about tonight are not. I had a patient earlier today with fibromyalgia, and we were able to actually start to adjust his medications, and he's starting to get his memory back. I had another lady, remember the D in dementia stands for drugs or depression. I had another lady with rheumatoid arthritis, and she was on a load of pain medications. Once we adjusted those medications, guess what? She was diagnosed with Alzheimer's, and I was able to remove that diagnosis of Alzheimer's because her memory came back because it was a drug interaction that was causing that. Let's see here. I'm trying to get to all these questions. He cannot take Aricept because of the side effects. Listen, I'm not a huge fan of Aricept. It's okay in the early stages, but later on, less medications are the better. If you can't try the Aricept, then you might want to look at maybe Namenda. Namenda was a medication that was first published in the New England Journal of Medicine, and sometimes it can be a little bit safer than Aricept. what diagnosis tool would be used for persons with pacemakers? So if they have a pacemaker and can't do an MRI, then we have to do the neurocognitive testing. So if we can't get the imaging, I'm going to look at labs, and then I'm going to do the neurocognitive testing, because we have one piece of the imaging that we can't rely on for the diagnosis. We don't necessarily have to have the MRI, but it is helpful. We can make a diagnosis even through the neurocognitive testing itself. I'm in Texas. Go Longhorns, by the way. Great information. Thank you very much. Thank you, Paige, for that. Do you have any experience with early dementia? So early onset is what I'm thinking that we're referring to here, Deborah. As a caregiver, I'm wondering when I should be screened. So different types of Alzheimer's, as I mentioned. We have late onset Alzheimer's, which means that gene has mutated around the age of 80. Early onset Alzheimer's are the ones that we see in the late 60s, like Grace. She would be an early onset. If you've never seen the movie Still Alice, I would recommend watching that if you're interested in early onset Alzheimer's. Actually, the person that contributed to the information in that movie is a neuroscientist. But early onset starts, again, in that age range. And then we have two kind of rare genetic or a gene mutation called presenilin 1 and presenilin 2 mutations. And those are your patients that develop Alzheimer's in their late 30s or early 40s that tend to be quite a bit more rare. Let's see here. What are your thoughts on Ambien in Alzheimer's? My thought is very, so Annie asked this question. It is a contraindicated. I would never recommend using Ambien for dementia patients. They can have sleepwalking, they can have behaviors, they can have really weird behaviors at night, and they don't quite get to REM sleep. We have to have REM sleep for memory. And that's one of the reasons we see, patients like vascular dementia or Lewy body and Parkinson's patient have so much problems because they're not reaching REM sleep, which we call REM sleep disorder. So I hope that helps with that question. But Ambiens, I would not recommend Ambien with any form of dementia. But my husband refuses to have the MRI. How do I convince him to do the test? Good question. I have gotten to where I can do neurocognitive assessments with patients, because let's be honest, patients a lot of times are very, very sensitive about this. Some of them want to be in denial. I had a patient just the other day told me, he said, if I have Alzheimer's, I'm going to kill myself. So I stay away from that diagnosis completely. I don't even talk to him about it, but I can talk to him about, hey, where are you from? Where'd you go to school? Well, guess what I'm doing? I'm establishing rapport, but I'm also testing their remote long-term memory. And then I move my questions almost in a conversational pattern to be able to move into more current events. And then I can start to pick up on where that patient begins to break down. So even if they're reluctant to be tested, they can still be tested through more of a conversational type format. Of course, looking at the history of the labs, those types of things as well. Let's see here. I'm scanning through some more of the questions here. Make sure I didn't miss any. Give me 1 second here. I know there was a couple here I missed here. Going up. Let's see. We talked about the COVID. Okay, another one popped in down here. What is preferred a cognitive test? Thoughts on the MoCA? The MoCA test, typically patients will score a little bit poorer on the MoCA because the words that they have to remember is at the end. See, that's why I don't like the mini mental status exam, because it's not giving enough time for them to lose the information that we're giving them. So I do the slums, and I also do the MoCA as well. MoCA does bring in a couple other areas like attention and a couple other areas that we can assess in that quick little cognitive test that the slums and of course the mini mental does not test. Let's see here. Great presentation. Thank you, Dr. Hutchings. Thank you, Dorothy, for that information. I appreciate the feedback. Elizabeth, when you're trying to rule out dementia being brought on by medication, when would you think this is the case, and how do you go about testing for that? So patients that have more of a medication-related dementia can do a lot of other things from a cognitive standpoint. So we talked about cognition as this big picture. Everything you do is cognitive. So in medication issues, they may have some symptoms like issues with concentration, maybe some short-term memory issues, but they're able to do a lot of other things. And if I also see that the memory issues are coinciding with the medication administration, then I also know that that certainly could be a factor. But when you do the testing, you can see that they have poorer scores in certain areas that we would see the opposite for maybe an Alzheimer's. These are great questions, guys. Is there such thing as medicated induced dementia? Absolutely. I mean, polypharmacy is a big deal. It's not uncommon for us to see a patient on 20, 25, or 30 different medications. And a lot of these medications impact the brain chemicals, the neurotransmitters. They impact a lot of different things that are going on in the brain. So yes, medication-induced dementia is very common. I would also say that also falls under the letter T in dementia as toxicity. Again, anesthesia, that could be a piece of that. So we want to rule these things out before we say this is Alzheimer's. I think we're very quick at a medical community sometimes just to say, we go in, we do a quick little cognitive test. Maybe it's the MoCA, maybe it's a mini mental status, and we say, you got Alzheimer's. And there are so many times I go in and say, this is not Alzheimer's, this is vascular. And I'll give you an example on this. My father-in-law was diagnosed with Alzheimer's. He was in Kansas City. And I knew they were wrong. I knew he had Lewy body, but they put him on medication. And he was unable to walk, talk, feed himself, use the bathroom. He was unable to do any of these things. We transferred him from Kansas City actually to a Pointe facility where he's under the care of Blue Sky and also myself. We changed his medicines because he was on a medication regimen for Alzheimer's, not for Lewy body. And within a week and a half, he was able to walk, talk, eat, take his medicine, go to the bathroom, because we had the right medication on the right type of dementia. Let's see, are there surveys? Michelle, you asked a question, are there surveys easily available? Thank you for the great information. Can you type in another, what do you mean by surveys? And I hope I can answer that question for you. I'm gonna bounce up this one here. What are your thoughts on CBD for dementia? A lot of people are asking me this right now. I would say that I think it's promising, I really do. Because it is releasing neurotransmitters, brain chemicals to help relax patients. However, there aren't FDA regulations on CBD, and the research is definitely still out there. So I'd be very careful on what we're giving them because we don't really truly know what's really in it. My mother is in memory care for the last 2 months. When I go visit her, she pleads for me to take her out because she is in prison. And they don't work her too much. She's not getting stimulated enough. Do the visits agitate her? Suggestions. She has a vascular dementia stage 6. The visits can create some agitation. Remember, and I didn't talk about this tonight, but every dementia patient does have a trigger, and we try to find what that trigger is. Maybe it's a spouse. Maybe it's a child, a daughter or son. So that certainly could be an issue in terms of a trigger. I would suggest, visiting her or even taking her out. Yes, you can take her out for sure. But what I would suggest is making sure that it's an environment that doesn't have a lot of environmental stimuli. Okay, our brains process up to 4 million things a second. And this is a poor analogy, but hang with me here. Imagine taking an autistic child to Cracker Barrel. It's a loud environment. They can't process all these different things that are coming in. Think about the same thing for a dementia patient. They can't attend to a task. They cannot filter out the lighting, the noise, all this stuff, and that can increase the anxiety. So definitely take your mom out, have quality of life, spend time with her, but also realize that it needs to be an environment that doesn't have a lot of environmental stimuli. Let's see here. I'm trying not to miss any of these questions. Oh, okay. So Michelle came back. Are the surveys easily available, like the slums, the caregiver? Yeah, you can find them online. The slums, the St. Louis mental status exam, that's online, which is the slums. The MOCA is as well. And so is the mini mental status exam. So you can actually, give those yourself if you'd like to at home as well. Let's see. My husband was bitten by a yellow jacket and loss of consciousness, got admitted to the hospital. I'm wondering if this incident causes memory loss or may not, because I noticed before the incident that he had forgotten the route which we were going. It could have exacerbated it. So we had a toxicity. We had an allergic reaction, quite possibly, but we had dementia before. So that excuse me, that creates inflammation in the brain, which can exacerbate or make whatever he had going on before. Let's say it's Alzheimer's or whatever it is. It certainly could have made it worse. Yes, that's a very, very good question. Gail's asking a question saying, 93-year-old mother, lost her husband 70 years last year in memory care and is sad and depressed. When I visit her, she always wants to leave. I have been told that she has Alzheimer's, but no specific stage. What do I do next? Number one is we got to take care of the depression. That's one big thing. I mean, you think about having been married to somebody for so long and then they lose them. Of course, they're going to be depressed. I mean, anybody on this conference tonight would be depressed. So I would focus on the depression first. Next, I would make sure that we do have at least a dementia stage and confirm, is this truly Alzheimer's? At her age, I would suspect that it probably is. But to muddy the waters here, we can have a vascular dementia and an Alzheimer's. And now we have a mixed dementia. Sometimes they'll mix. So we'll definitely need to make sure that that's not the case where we are treating it effectively based on what she has there. But I will say too, that if she is clinically depressed, which I mean, she has every reason to be, it can certainly make the depression or make the dementia itself worse. Y'all got a lot of great questions here. I want to make sure I'm not missing anybody here. Let's see, going up here. We still have time for a few more questions before I got some closing remarks too, but want to make sure I'm getting to everybody's questions here. Let's see, make sure I didn't miss any from the top. I love Lisa. Thank you. Yeah, absolutely, we can make a difference to these patients. Absolutely. Okay, got another message came in. After surgery, so this comes from Timothy. After surgery recently, my mom appeared to have most clear memory and understanding of what was going on around her that I've seen in a year. That's great. The next day, she had, it's got another message. She had done a 180. So she completely, obviously started to have some fluctuations there. Why did this happen? And then was it intentionally created? So that is actually fairly common after anesthesia. Patients sometimes can perk up for a little bit, but that anesthesia stays in the system for quite some time. So after waking up, we may have been perked up, we may have been more lucid, but that toxicity is still in the system. So that's a reason why you may have seen a little bit of a relapse there. Kathy asked a question. I had a grandmother with Alzheimer's. Hold on one second here. Make sure I'm getting this right. I had a grandmother with Alzheimer's. How concerned should I be about the genetic component? If your grandmother was late onset Alzheimer's disease, remember, that's not always genetic, okay? So just because we have a family history does not mean that we're gonna acquire Alzheimer's. If it's late onset Alzheimer's. Now, if a patient had it in their 40s and 50s and 60s, there is a much higher genetic component to that. So I hope I answered that question. And I think we have time for one more question, everybody here. This comes from Pearl St. John. in existing memory issues, undiagnosed, extremely stressful situations like the death of a child, for example, or yes. When it comes to a great loss like a child or a husband or any kind of post-traumatic stress syndrome, all of those can certainly impact and make memory worse and make the dementia worse. Remember, we're treating multiple conditions here. We're treating the dementia, we're treating the depression, and also we're treating the anxiety and the insomnia and the mobility issues and the eating and swallowing issues. So there's a lot going there. But again, I think Pearl brings up a really good question here, because whatever happened before in that patient's life is going to be impacting that patient when they acquire the condition. Okay, I'm gonna take one more question here, and then we're gonna closing comments. Okay, I wish we could keep going. I'm having a ball with this. I'm loving your questions here. Okay, how do I get my mom the medical care she needs when she doesn't remember the diagnosis or memory loss that insists and she's fine? You know what? We can work around that. Okay, I don't think it's necessarily that we need to tell her that she has this condition. A lot of times I don't tell my patients at all because I don't see the point. It's just going to increase their anxiety. So if we can at least get some testing with her, whether it's neurocognitive testing or a quick imaging, we can know we have a diagnosis and be able to move forward with that's the diagnosis. But we may not tell her that's what she has, because that can increase the psychosis. And then Joseph said, thank you, a great presentation, very helpful, from New York City. Okay, I know we're running out of time. I would love to continue to take questions. I really would. I'll end this tonight by saying I believe in what we do, and I believe we can make an impact on these patients. I study every single day, and I work with these patients every single day. And I know that if it's my loved one, I want to know what type is this, what stage are they, and how do we treat this to the best of our ability. Our medical team needs to be all on the same page. And at the end of the day, this is your loved one. You are the advocate for that patient and for that loved one. And I would definitely be asking for the very same things we've been talking about tonight. And I'll also say that I'm a strong Christian, and I will tell you right now that all of you I pray for. I know the journey. My sister at 43 passed away with dementia. I know what it's like. I've seen it with my stepfather, my father-in-law, and I'm going to continue to fight. I not only know the medical side of this, but I also know what it's like to be a caregiver as well. So my heart goes out to all of you. My prayers go out to all of you. And remember, we can treat it, and we can give these patients quality of life. So again, I wish we had more times for questions, but we're kind of running out of time. Hope I'll be invited back by Morning Point, and if I am, I'd be gladly to come back and cover any topics that y'all like me to cover. Thank you again, everybody, and good night.
Thank you again for joining us for another Morning Point Foundation Virtual Caregiver Cafe. And thank you, Dr. David Hutchings, a regional dementia specialist, for sharing your expertise. Be sure to join us on May 26th at 6:30 p.m. Eastern Standard Time for our next Caregiver Cafe. The topic, how a multi-sensory approach can help caregivers better communicate and engage adults living with dementia. Our guest speaker, Dr. Elizabeth Rodas, an assistant professor at the University of Kentucky and with the Sanders Brown Center on Aging. And don't forget, you can join us live at 6:30 p.m. Eastern Standard Time, or just by registering, you can watch at your convenience. Until next time, thank you for joining us for the Morning Point Foundation Caregiver Cafe Virtual Educational Series.